Hello, today we will be talking about rotator cuff tendinopathy. My name is Lily Yu.
I'm Yuxin Zhou.
Here's our outline for our presentation. I'll start off by introducing rotator cuff tendinopathy. The rotator cuff muscles, which include the supraspinatus, infraspinatus, teres minor, and subscapularis, are considered as the shoulder protector muscles. The rotator cuff muscles have important functions to assist in the rotation of the shoulder and arm, to reinforce the glenohumeral joint capsule, and to control the active arthrokinematics of the glenohumeral joint as well. Rotator cuff tendinopathy is defined as pain and impaired performance associated with injury to the rotator cuff tendons. The incidence of rotator cuff tendinopathy ranges from 0.3 to 5.5% and annual prevalence from 0.5 to 7.4%. 50 to 70% of shoulder patients seen by clinicians are related to rotator cuff pathology. Rotator cuff pathology can be caused by intrinsic and extrinsic factors. These factors are shown in the following figure. Next, we will move on to the diagnosis. There are many special tests that can be used during the physical exam that have varying sensitivity and specificity for diagnosing rotator cuff pathology. We will discuss these special tests later in the presentation. The physician can order several different types of imaging. An MRI is the gold standard for characterizing the size, location, and repairability of the rotator cuff. With rotator cuff tendinopathy, the MRI will demonstrate an increased T2 weighted signal and show increased whiteness within the tendon. An ultrasound can be used when MRI is not available or the patient has contraindications for an MRI. This test uses sound waves to produce images of structures in the shoulder, particularly soft tissue structures. An X-ray can be used to visualize bone spurs or osteophytes or other potential causes of pain, but it will not be able to show a rotator cuff tear. Common signs and symptoms associated with rotator cuff tendinopathy. The patient will exhibit signs and symptoms of pain, muscle weakness, and loss of functional mobility with rotator cuff tendinopathy. The patient will usually complain of a dull ache, especially with overhead reaching, reaching behind the back, lifting activities, and sleeping on the affected shoulder. A characteristic finding is the painful arc, in which the patient experiences pain between 60 to 120 degrees of abduction. Patients may also be unable to achieve greater than 90 degrees of flexion and abduction. Patients may report clicking when raising the arm, loss of mobility, and strength and stiffness in the affected arm. Palpable tenderness of the biceps tendon and supraspinatus tendon is commonly found. The following graph shows the common trigger points and the referred pain patterns of the rotator cuff muscles. Potential common clinical findings in the physical examination. There are many special tests that can be used to diagnose for impingement of a rotator cuff tear. To test the supraspinatus, you can either use a full can test with a thumb up or the empty can test with a thumb down. The patient is tested in 90 degrees elevation in the scapular plane and full internal rotation with the empty can, or 45 degrees external rotation for the full can. The patient resists downward pressure exerted by the examiner at the patient's elbow or wrist. Another sign that the supraspinatus is affected is the drop arm sign. The examiner passively abducts the patient's shoulder to 90 degrees. The examiner releases the patient's arms with instructions to slowly lower the arm. The test is positive if the patient is unable to lower his or her arm in a smooth, controlled fashion. To test for both the teres minor and infraspinatus is the external rotation lag sign. The examiner passively flexes the patient's elbow to 90 degrees and brings the shoulder into a position of 20 degrees of scaption. Next, the examiner passively takes the patient's shoulder into a position of maximal external rotation. The patient is then instructed to hold that position. A positive test is if the patient cannot maintain the position and the shoulder rotates internally. If the patient has a positive external rotation lag sign, then the therapist can test specifically for the infraspinatus or teres minor. For the infraspinatus test, the patient stands with the arm at the side with the elbow at 90 degrees and the humerus medially rotated 45 degrees. The patient resists an internal rotation force applied by the therapist. The pain or inability to resist medial rotation indicates a positive test for an infraspinatus strain. One sign that the teres minor is affected is the hornblower sign. The therapist elevates the patient arm to 90 degrees in the scapular plane. The therapist then flexes the elbow to 90 degrees, and the patient is asked to externally rotate the shoulder. The positive test occurs with weakness or pain or compensatory patterns with using the upper trap and leading toward the contralateral side. The lift-off test is used to test the subscapularis. The patient stands and places the dorsum of the hand against the mid-lumbar spine. The patient then lifts his hand away from the back. An inability to perform this action indicates that the subscapularis muscle is affected. The Neer test and the Hawkins-Kennedy test are tests for impingement, and the most commonly involved tendon is the supraspinatus. For the Neer's test, the examiner internally rotates the patient's arm and forcefully moves the arm through the full range of forward flexion or until reports of pain. The test is positive if pain is reported in the anterior lateral aspect of the shoulder. For the Hawkins-Kennedy test or 90-90 test, the examiner moves the affected arm with the shoulder in 90 degrees of forward flexion and the elbow flexed to 90 degrees. The examiner then moves the patient's shoulder into internal rotation to in range of motion or until reports of pain. The test is considered positive if pain is reported in the superior lateral aspect of the shoulder. Physical therapy intervention. The physical therapy intervention for treating rotator cuff tendinopathy is based on stages of healing. The general rotator cuff rehab program is divided into 4 stages. The first stage is the acute stage, and the goals of this stage are to reduce pain and inflammation, protect the injured tissue, and improve range of motion without aggravating symptoms. In this stage, the patient should avoid any lifting, pushing, pulling, or carrying activities. Exercises for this stage include pendulums and passive range of motion exercises. The second stage is the subacute phase. The goals of this phase are to continue to protect the healing tissue, continue to improve passive range of motion, initiate active range of motion with proper scapulohumeral rhythm, initiate light rotator cuff strengthening. Exercises for this stage include active assisted range of motion, scapular retraction, external rotation, and internal rotation with a TheraBand, standing scaption, prone extension, and prone horizontal abduction with dumbbells. The third stage is the progressive strengthening phase. The goals of this phase are to continue to increase range of motion, progressively strengthen the rotator cuff, and restore functional use of the arm. Patients should incorporate strengthening exercises with a TheraBand or dumbbells, including standing or prone scaption, internal rotation, external rotation, and PNF diagonal patterns. In addition, the patient should work on eccentric exercises of the rotator cuff, rhythmic stabilization, proprioceptive drills, and push-up progressions. The fourth stage is a sport-specific phase. The goals of this phase are to continue to progress the arm for functional activity and return to sport. The patient will incorporate plyometric exercises and sport-specific training with a gradual return to normal activity. Prognosis. A proportion of patients will improve in the short term, but a significant number will go on to develop persistent pain and disability. A cohort study done by the Moon Shoulder Group in the Journal of Shoulder and Elbow Surgery consisted of 452 patients with atraumatic full-thickness rotator cuff tears and demonstrated that physical therapy is effective in approximately 75% of patients followed for 2 years. Patients receiving physical therapy treatment showed significant improvements in range of motion, especially forward elevation and abduction, and improvement in validated outcome measures as well. Outcome measures used for the shoulder. There are several outcome measures used to measure shoulder disability. The Simple Shoulder Test, or SST, is the standardized self-assessment of shoulder function with 12 yes or no questions. Compared to other questionnaires, the Simple Shoulder Test takes the shortest amount of time to complete, is the easiest to score, and has the highest test-retest reliability. The Shoulder Pain and Disability Index, or SPADI, is a self-administered questionnaire that consists of 13 items that assess 2 domains, a 5-item subscale that measures pain and an 8-item subscale that measures disability. The SPADI takes 5 to 10 minutes to complete. The Disabilities of Arm, Shoulder, and Hand, or DASH, is a 30-item self-administered questionnaire that measures the impact of function of several musculoskeletal disorders of the upper extremity. There is also a shorter version called the Quick Dash that is 15 to 20 questions. The American Shoulder and Elbow Surgeons, ACES, Standardized Shoulder Form, is an assessment of patient-related shoulder disability and function. It consists of 1 pain question on a visual analog scale and 10 questions on function and disability. The minimal clinically important difference, or MCID, is approximately 6.4 for the ACES and 10.2 for the DASH, and between 8 to 13 for the SPOTY. The MCID has not been defined for the SST. And here are references. Thank you.
Thank you.